Hello everyone and welcome to our module on antipsychotics. Antipsychotic drugs are based on the dopamine hypothesis. This comes from the 1950s when the drug chlorpromazine was found to improve psychosis in patients with psychotic disorders. Further study of the drug found that it blocked CNS dopamine receptors, and this led to the dopamine hypothesis, which states that excess dopamine is what leads to psychosis, and therefore if you block dopamine, you will improve psychotic symptoms. Chlorpromazine is a member of a group of drugs called first-generation or typical antipsychotics. These were the first antipsychotic drugs to come on the market in the United States. Most of them end in azine, like chlorpromazine or thioridazine, although there are two exceptions to this. Haloperidol is a first-generation antipsychotic, and so is pimozide. And the primary antipsychotic effect of all these drugs is blocking the D2 receptor that binds dopamine in the central nervous system. In the neurology section, I have a video on Parkinson's disease where I talk about this disorder, which involves motor dysfunction, tremors, and rigidity. And the cause of Parkinson's disease is a decreased amount of dopamine activity in the central nervous system. So if you know that, it's an easy way to understand that many of the side effects of antipsychotic drugs involve motor symptoms that mimic Parkinson's disease. You are essentially causing a variant of Parkinson's disease by giving a drug that blocks dopamine. Another basic principle of antipsychotic drugs is that although these drugs are designed to block dopamine, they also block the effects of many other central nervous system neurotransmitters that are small molecules just like dopamine. This includes blocking the effects of histamine and serotonin and epinephrine and acetylcholine. All of these other neurotransmitters are small molecules like dopamine, and so their activity is often affected by drugs whose intended effect is just to block dopamine. So all of the first generation or typical antipsychotics block dopamine, but they also block the effects of other neurotransmitters, including serotonin, histamine, acetylcholine, which means blocking muscarinic receptors, and epinephrine, especially alpha-1 receptors. And different drugs have different affinities for the receptor subtype. So for example, chlorpromazine has its greatest blocking effects on alpha-1 and serotonin receptors. Serotonin receptors are also called 5-HT receptors. And they block these receptors more than they block dopamine. Haloperidol, on the other hand, which is also a first-generation drug, blocks dopamine more than alpha-1, more than serotonin, and it blocks histamine the least. And so each of these first-generation drugs has a profile like this of which receptors they block the most and which they block the least. Because all of the first-generation antipsychotics block dopamine, they all have side effects related to dopamine blockade. The first of these are movement side effects called Parkinsonian effects. They're also called extrapyramidal side effects, and we'll talk about these movement side effects in a minute. Dopamine inhibits prolactin release, so when you block dopamine, this will necessarily elevate the serum prolactin and cause hyperprolactinemia. Prolactin's physiologic role is to stimulate breast tissue, so when prolactin levels go up, patients can develop gynecomastia and galactorrhea. Prolactin also shuts down LH and FSH release from the pituitary gland, so this will cause amenorrhea in women. And then lastly, dopamine is very important in mediating nausea and vomiting in the brain, so when you block dopamine, this will have an antiemetic effect. And two first-generation antipsychotics, prochlorperazine and chlorpromazine, are still used today as antiemetic drugs. You'll sometimes see these given in the emergency room to patients with significant nausea and vomiting. Other side effects of first-generation antipsychotic drugs are shown on this slide. Because these drugs block acetylcholine muscarinic receptors, they cause dry mouth, which is xerostomia, as shown in this picture on the screen. They also cause constipation, urinary retention, tachycardia, and sexual dysfunction. The alpha-1 receptor blockade leads to hypotension, especially orthostatic hypotension. Patients on first-generation antipsychotics can get dizzy when they stand up for this reason. And then blockade of histamine receptors leads to sedation and weight gain. To understand the movement symptoms of antipsychotic drugs, you have to understand what the words pyramidal and extrapyramidal mean. The pyramidal system in the brain refers to the corticospinal tract. It gets its name because corticospinal fibers run in the pyramids of the medulla. And so damage or dysfunction of the pyramidal system leads to motor weakness. The extrapyramidal system refers to the basal ganglia, nuclei, and associated tracts, and their role is to modulate movement. So when you have damage or dysfunction of the extrapyramidal system, this does not lead to weakness or paralysis. Instead, it leads to abnormal movement and movement disorders. And this extrapyramidal system is highly dependent on dopamine, and so when you block dopamine with antipsychotic drugs, you get extrapyramidal side effects. It's not that the patients get weak or paralyzed, It's that they cannot coordinate their movements. So we call these side effects of antipsychotic drugs extrapyramidal symptoms. They are the response of the brain to dopamine receptor blockade, and they are all movement side effects. And they come in four major types: dystonia, akathisia, bradykinesia, and tardive dyskinesia. And we'll talk about all four of these in the next few slides. Dystonia is an acute side effect of dopamine blocking drugs. It occurs within hours or days of taking the medication. It refers to an involuntary contraction of muscles. Patients often complain of spasms or stiffness after they've received a dopamine blocking drug. You may have had writer's cramp yourself. Writer's cramp is an example of a dystonic reaction. It's similar to the type of reactions you can get with antipsychotic drugs. Although the symptoms don't necessarily occur in the hand, they can occur in the neck or anywhere else in the body. The treatment for these stiff and spasm muscles includes benztropine, which is an anticholinergic drug. The cholinergic system in the brain blocks the dopamine system in the brain, so if you knock down the cholinergic system, you increase dopamine effects, and that can relieve dystonic reactions. You can also use diphenhydramine, which is an antihistamine, but it also has anticholinergic effects. Both of these drugs will improve the dystonia that can be seen in patients who have received first-generation antipsychotic drugs. Akathisia is a reaction that occurs usually a few days after being treated with an antipsychotic drug. It's the most common EPS adverse effect of first-generation drugs. And the easiest way to understand akathisia is it's basically a restlessness and an urge to move. These patients are fidgety and can't stop moving. Sometimes if you've given a drug to treat psychosis, the akathisia can be misdiagnosed as worsening agitation, when in fact it's an adverse effect of the drug. Treatment options include lowering the dose, because this is a dose-dependent side effect, or using benzodiazepines or the beta blocker propranolol. Bradykinesia is a movement side effect. It's an extrapyramidal symptom that occurs in patients who have been taking antipsychotic drugs for a few weeks. Bradykinesia is also called drug-induced Parkinsonism, and it involves slow movements similar to those that occur in patients with Parkinson's disease. So bradykinesia leads to difficulty initiating movements and difficulty walking, all related to slow, limited movements. Like dystonia, this can also be treated with benztropine because it has those anticholinergic effects that help to boost dopamine effects and relieve the bradykinesia. A second-line treatment is amantadine. Amantadine is an antiviral drug, but it also has anticholinergic properties like benztropine. The last extrapyramidal side effect is tardive dyskinesia. The word tardive means late, and therefore this is a late side effect that only occurs in patients who have been taking first-generation antipsychotic drugs for months or years. The main feature of tardive dyskinesia is chorioathetosis. Chorea means irregular migrating contractions of muscles, and athetosis means twisting and writhing. And so essentially what this means is that patients who have tardive dyskinesia and chorioathetosis are constantly moving and twisting their muscles. You can see this in their mouth, tongue, face, or limbs. Usually it's most obvious in the face. These patients are constantly smacking their lips or grimacing from chorioathetosis. This is the most feared movement side effect of antipsychotic drugs because it's often irreversible and stopping the drug doesn't help. There's one FDA-approved drug for treatment of tardive dyskinesia. It's called valbenazine. It inhibits an enzyme called VMAT2, which is found in neurons, and this enzyme packages dopamine into vesicles. So by inhibiting it, less dopamine is put into vesicles and less dopamine is released into synapses. The reason this is believed to be beneficial is because there's evidence that tardive dyskinesia occurs because neurons have become hypersensitive to dopamine after patients have been on dopamine blocking drugs for years. So by giving valbenazine and depleting the dopamine that gets released by neurons, this has some benefit on the movement symptoms. You can divide the first-generation antipsychotic drugs into high-potency and low-potency agents. Some of the high-potency agents are haloperidol, fluphenazine, and pimozide, and they're called high-potency because it requires a lower dose to achieve the desired effect. For example, the standard dose of haloperidol is only 1 milligram. In general, the high-potency agents have little effect on histamine and muscarinic receptors, so they cause less sedation from blocking histamine and less dry mouth from blocking muscarinic receptors. The high-potency drugs do, however, have more extrapyramidal side effects compared to low-potency drugs. If you look at the bottom of the screen, haloperidol blocks D2 receptors more than many other receptor types. For that reason, it's going to have more extrapyramidal side effects, but less side effects related to blocking things like histamine. Lower potency agents were drugs like thioridazine and chlorpromazine, and they're low potency, so they require a higher dose. For example, the typical dose of thioridazine is about 50 to 100 milligrams. These drugs have less extrapyramidal side effects but more non-neurologic side effects, especially sedation, Back in the old days, doctors who did house calls always carried a vial of chlorpromazine in their doctor bag, and that's because you could inject this intramuscularly as a sedative if necessary. The low potency agents also cause lots of dry mouth. And you can see this in the profile for chlorpromazine on the bottom of the screen. It has less D2 blockade, that's why it causes less extrapyramidal side effects, but it blocks other types of receptors more than dopamine. So first generation antipsychotics really occur along a spectrum from the low potency agents to the high potency agents. The low potency agents have non-movement side effects, things like sedation and dry mouth, but less movement side effects. The high potency agents are the ones that have the movement side effects and can cause extrapyramidal symptoms. The neuroleptic malignant syndrome is a rare, dangerous reaction to neuroleptic drugs, and first generation antipsychotics are called neuroleptic drugs. Usually the drugs that cause this are high-potency first-generation drugs like haloperidol or fluphenazine. NMS usually develops after a patient has been taking one of the first-generation drugs for 7 to 10 days. This is a muscle disorder, so the dominant clinical features are fever and rigid muscles. Patients also develop mental status changes from encephalopathy. And because NMS involves muscle damage, creatine kinase will be elevated in the plasma. There will also be myoglobin in the plasma that enters the urine, causing myoglobinuria, and this leads to acute renal failure by the same mechanism you see in cases of rhabdomyolysis. NMS is very rare in the modern era because we usually don't treat patients with first-generation drugs for 7 to 10 days in a row, but back in the day when this used to occur more often, the treatment was with dantrolene, which was a muscle relaxant, or bromocriptine, which was a dopamine agonist that could overcome the dopamine blockade of those high-potency first-generation agents. And you can think of NMS as similar to malignant hyperthermia, which is also a muscle reaction. It occurs in reaction to anesthetics like halothane and succinylcholine. It has a similar presentation, and it has the same first-line treatment, which is dantrolene. First-generation antipsychotics can block cardiac potassium channels, and this can prolong the QT interval and put patients at risk for the arrhythmia torsade de Pointes. The strongest association with QT prolongation is with the first-generation drug IV haloperidol. Back in the day when thioridazine and chlorpromazine were administered chronically to patients with psychiatric disorders, they could lead to problems in the eyes. Both drugs can cause retinal deposits. They can cause brown deposits in the eyes, similar to what's shown on the screen here. This resembles the retinal disorder retinitis pigmentosa, and it can cause browning of the vision. This problem only occurred with higher dosages of these drugs, so lower dosages were used to avoid this complication. And it was most common with thioridazine because that drug requires higher doses to be effective. And then both drugs could also cause corneal deposits. They could cause dark deposits to appear in the cornea, like what's shown on the screen here. And this could accelerate aging of the lens and possibly increase the risk of cataracts. Chronic use of chlorpromazine has effects on the skin. First of all, it causes photosensitivity in sun-exposed areas, so patients who are taking this drug sunburn easily. And then rarely it can lead to deposits in the skin, which can cause the skin to develop a blue-gray pigmentation. This is a picture of what it looks like on the screen here. And then patients on long-term chlorpromazine therapy can sometimes develop cholestatic jaundice. This occurs in about 1 or 2% of patients. First-generation antipsychotics are rarely used in the modern era. They've largely been replaced by second-generation drugs, which we'll talk about in a minute. And that's because when you gave first-generation drugs on a daily basis, they developed many of the side effects we've been talking about so far. In the modern era, there are just a couple of common uses for first-generation drugs. In patients who are acutely agitated or confused, you will sometimes see a one-time dose of haloperidol administered in order to settle the patient down. And then in the emergency room in patients who have nausea and vomiting, you'll see the first-generation drugs prochlorperazine and chlorpromazine given, and that's because they are effective antiemetics. When you only give the drugs as a one-time dose on a short-term basis, you won't see the long-term side effects we talked about, like tardive dyskinesia and things like that. You can, however, see a dystonic reaction because this can occur immediately after receiving one of these drugs, and you can also see QT prolongation because this effect can also occur immediately after a one-time dose. In the modern era, the antipsychotic drugs that you will see used most commonly are the second-generation or atypical antipsychotics. And the reason these drugs are so popular is because their defining feature is that they have a lower risk of extrapyramidal adverse effects compared to the first-generation drugs. I've listed the important second-generation antipsychotics on the screen here, but you can basically divide them into two groups. The first group are the pines. These drugs all have names that end in pine. And among the second-generation agents, these have the lowest risk of extrapyramidal side effects. In fact, among all the second-generation agents, quetiapine has the lowest risk of extrapyramidal adverse effects, and many people remember this by the mnemonic quetiapine is quiet. The other group of second-generation agents are the dones. All of these drugs end in the word done. These have the highest risk of extrapyramidal symptoms among the second-generation agents, especially if you give them at high dosages. The drug that has the highest risk of extrapyramidal adverse effects among all second-generation drugs is risperidone. So although the risk of extrapyramidal symptoms is lower for second-generation agents, it is not zero, and risperidone has the highest risk among all the second-generation drugs. In the video on substance abuse, I talk about the illicit drug LSD, which is lysergic acid diethylamide. LSD works as a serotonin agonist, and it's believed to produce hallucinations by activity on the serotonin 2A receptors. And so because people knew that the 2A receptors led to hallucinations, they started studying the effects of antipsychotic drugs on the 2A receptor. And it's believed that blockade of serotonin 2A receptors occurs with many atypicals, and that's what leads to their antipsychotic properties. In fact, most of the second-generation drugs are defined by more effective blockade of serotonin than dopamine. For example, Clozapine blocks serotonin more than dopamine, and so does olanzapine. And this is believed to be one of the reasons that these drugs are effective antipsychotics while causing less extrapyramidal symptoms. The metabolic syndrome can occur with any antipsychotic drug, but it's most common with drugs that are pines, especially Clozapine and olanzapine. The metabolic syndrome consists of weight gain, hyperglycemia, and hyperlipidemia, and when you treat patients with psychotic disorders, you will see that many of them put on weight, and that's because they are taking some of these drugs that cause the metabolic syndrome. We talked about how the QT interval can become prolonged by first-generation drugs. This can also occur with second-generation atypical drugs. The risk is higher with the second-generation drugs that are dones, and of all the second-generation drugs, the highest risk for QT interval prolongation is with the second-generation drug ziprasidone. Clozapine is a second-generation drug that is highly effective in many disorders, but its use is limited because of adverse effects, so it's generally only used in refractory cases. The most dangerous adverse effect of this drug is agranulocytosis. This occurs in up to 2% of patients, and it essentially means that their white blood cell count plummets and they become at risk for infections. So in patients taking Clozapine, you have to monitor the white blood cell count during therapy. You do it every week when they start the drug, and then every few weeks thereafter, and you stop the drug if the neutrophil count falls below 1500. The agranulocytosis is reversible when the drug is stopped, so if you pick it up, you can prevent the patient from developing serious infections. Clozapine can also cause seizures in up to 5% of patients. This is dose-related, so the lower dose you use, the less likely seizures are to occur. And then there have been rare cases in which Clozapine use was associated with development of myocarditis. Hyperprolactinemia is very common with antipsychotic drugs. In fact, antipsychotic drugs are the most common drug-induced cause of high prolactin levels. And this is because all these drugs block dopamine, and that leads to high prolactin like we talked about before. So that will stimulate breast tissue, and that can cause gynecomastia in men and galactorrhea, and it causes amenorrhea in women. The highest rates are with the two first-generation drugs, haloperidol and fluphenazine, which, as I told you before, are rarely used chronically in the modern era, so this really isn't an issue. The highest rates among the second-generation drugs are with risperidone and paliperidone, and so patients taking these drugs often have their prolactin level measured. It will always be elevated, but you don't want it to get too high, and then you have to monitor the patient for development of high prolactin symptoms like shown here. The last antipsychotic drug we'll discuss is aripiprazole. Aripiprazole is considered an atypical antipsychotic, but it has a unique mechanism of action. It's a partial agonist to dopamine D2 receptors, such that it exerts some blocking effects and some agonist effects. And this drug was designed with the goal of blocking dopamine effects and limiting psychotic symptoms, but having agonist effects on dopamine receptors to minimize the side effects. In the clinical studies, hyperprolactinemia was very rare and almost unheard of with this drug, so that's one good thing about it. It also appears to have less weight gain and sedation than some other second-generation agents. Its most common side effect is the movement side effect akathisia. And then one special thing to know about aripiprazole is after it came on market, there were reports of patients losing impulse control while on this drug, and the FDA ultimately issued a warning. Some of the things patients have been reported to do while taking this drug are engage in activities like pathologic gambling, binge eating, or shopping sprees. I'll finish this video with this slide summarizing the important things you want to remember about the second generation or atypical antipsychotics. Remember that the pines are the drugs that cause metabolic syndrome, and olanzapine and clozapine have the highest risk of metabolic syndrome. The dones are the drugs that have the highest risk of QT prolongation, and among the dones the highest risk is with ziprasidone. The highest risk of extrapyramidal symptoms is also with the dones, and among all the dones risperidone has the highest rate of all second-generation agents of extrapyramidal side effects. Clozapine causes agranulocytosis, and so you have to monitor the white blood cell count. And then quetiapine has the lowest risk of extrapyramidal symptoms. Remember that quetiapine is quiet. And for that reason, this is the drug of choice if you need to treat psychosis in a patient with a movement disorder like Parkinson's. Patients with Parkinson's can develop dementia, and sometimes they need a drug to treat psychosis. And when this happens, quetiapine is the drug of choice because it has the lowest risk of movement side effects. And then the last drug we talked about was Aripiprazole. Remember, this is the drug associated with loss of impulse control. It has a unique mechanism of action. And that concludes our module on antipsychotics.